You guys asked for some really cool cardiac cath cases, so I've got two really cool ones. Both of them have some abnormalities and some anomalies on them. I want you guys to see if you can figure it out before I give it away. So enjoy these videos. Let me know if you like these. We can definitely do a lot more of them. All right, so today we're going to go over some cardiac cath cases. The first one is a little bit more normal, and then the other one has some anomalies on it that I want you guys to see if you guys can figure out. So here, usually I start my cardiac cath cases in the LAO cranial view, like I said, and then I kind of go four corners and I get more views if I need them. So take a look at this very first projection here. Obviously, you have the LAD up here. You have what looks like a ramus intermedius or maybe a high OM, depending on the angle. You can't really tell from this view. You've got the circumflex going straight down, and then it curves over this way, and you got some marginals coming off of it. Normally, in this view, you can tell which one is the LAD because you see septal perforators going straight up and down and filling. And that's kind of what you see there. Looks like there may be a stent there kind of in the middle or just a really heavy calcification. It appears to be like a prior stent or something else kind of going on there. It does look like maybe a stent or some calcium. The LAD definitely wraps around the apex, not completely, but definitely reaches the apex and wraps around. I think they call that a type 2 LAD. The next projection here, slightly different view. You see the LAD, you see the circumflex once again going down. Now the caudal views are usually better for the circumflex, but here you see the circumflex again. Nothing really too crazy. There are definitely some lumpy, bumpy lesions in both of these arteries, but nothing really stands out like it needs to be stented or anything like that. You see this, the small rest of the circumflex kind of goes this way, and then the acute marginal is going down. Here's another view where you see the LAD on the top again. In this one, you could clearly see the septal perforators coming down. And you don't see any diagonals. Well, there's one right there actually, and you can't tell if it's coming towards you or going away from you in this view because it's kind of like right there. But definitely you can see that the circumflex a little mangled here, so you can't see it as well. You definitely see that it does fill, and it does get small. There's a lot of like little 10 to 20% lesions here and there. Also, nothing screaming at you that it needs to be worked on. When the dye gets really dark like this, it's because the vessel's coming at you and you have dye stacked on dye. Hence, it looks darker in the fluoro. The next picture here is one we usually call this the spider view or like LAO caudal. This one is to see the ostia and the bifurcation of the LAD and circumflex. It's always very, very clear. You see the left main looks really long and large here as well. Nothing really blocking that. So the left side has some stuff, but nothing too wild. Over here on the right side, it looks like the catheter that they're using for this is on this side is a JL4 for the left, and on this side you got your normal JR4. Here in the RCA, you definitely see a lot more. You got like a really proximal lesion of about 40 or 50% there. As you follow this down, you see another one mid-distal almost, but you definitely see two distinct lesions there before the bifurcation. You also see something interesting on here. What would you call this branch? There appears to be a branch coming off really high from the RCA. Now, normally, when you see something like this, depending on where it travels, you might think this is like an anomalous circ, that the circumflex comes off the right. But just the way it looks and the shape of it, it doesn't go and travel back to the left side and fill the circ area. So it looks like it's just kind of filling there. It looks like an acute marginal or like an RV branch that comes off really, really high and has like the shepherd's hook at the top, and then of course you see like an SA nodal branch coming off of there kind of towards the very, very top before that large branch with the shepherd's crook or hook, some people call it. Um, but then when it comes down, you see that the RCA here doesn't split towards the end of the projection. It doesn't split into its traditional PLA and PDA. So that acute marginal, that large branch that comes down, this is probably the PDA, and this is probably the PLA, or like the distal RCA is the PDA, and this is the PLA. It's hard to tell with these views, but that's probably what's going on there. And then we have one more view of it, kind of here. You definitely see those two distinct lesions. You've got that proximal, almost mid one, and then you've got that like more distal mid one, right before the bifurcation would normally be. And obviously, there's no bifurcation on this one. Our next case is kind of a cool one. Here I started with the RCA. This one was done with a TIG catheter. The nice thing about the TIG catheter is you could do the entire case with one single catheter. You could do the RCA, the left main, and dip into the LV and do an LV gram, or just check pressures with the TIG catheter. So here's the TIG catheter. It went into the RCA first, so we started with the RCA. You definitely see there's a lesion in the distal RCA right before the bifurcation of the PLA and PDA. You see the acute marginal and RV branches look pretty good. There's a couple of different pictures we took of this, but definitely that lesion towards the end looks like a 30 or 40%er, that distal RCA. After that, we went to the left side, and what have we got here? I'll leave this up and I'll run it a few times. Take a look. You can kind of slow this down or go back and forth. But what have we got here? We cannulated the left main with that same TIG catheter, but clearly something doesn't look right. If you remember what the other left main looked like, or what the LAD and circumflex looked like, what do you see here? So clearly you see just an LAD. There's no circ. You see an LAD, some septal perforators, a few diagonals going off to the side. There is no circ, but if you watch closely and you go back and slow it down and go back and forth, you see the dye in the beginning of the projection kind of does fill a little bit of a circ. So this one, if you may have guessed this already, there is a circ. It just comes off its own ostia, or it has like its own takeoff from the aorta, or it's so high up in the left main that there really a left main doesn't exist, and there's really just two ostia. So what we did is we pulled the catheter back out a little and rotated it. And this is still the TIG catheter. We rotated it a little and flipped into the left circumflex, and then we were able to get better pictures. I'll just go through the rest of these. Here's another LAD picture. You see it's filling nicely, and it's mostly normal. There's a few, like maybe 10 or 20% lesions here and there, but nothing to write home about. You do on this last projection here with a lot of dye leakage, do see and circumflex filling. This is before we finally just cannulated the circ by itself. Here in this one, we did turn the catheter and pull it out a little and did fill the circ. You see the obtuse marginals coming off the side. You see the distal circ is very small, but that last OM looks really, really nice and large. We'll let this one run a little. But the circ looks okay, and you see some filling still of the LAD. So these are definitely coming off two different ostia that are near each other. We took a couple more views, and the caudal views are usually better for the circumflex artery. We eventually also took this TIG catheter and dipped it into the left ventricle, and of course you can inject dye with either a hand injection or an injector, power injector, or just take pressures and check the gradient across the aortic valve and get out. That will count as a cardiac cath as long as you dip into the LV. We do all of these radially, and the less equipment you use, the better. So using something like a TIG catheter where you can just do the whole thing with one catheter is obviously much better. So that's all for the images. I hope you enjoyed the virtual Cath conference. Subscribe to my channel and let me know if there's anything else you want to see. Here's a whole lot of other videos that you can enjoy.